Professor, if before we start for number one, can I find the answer?
Yes, yeah, of course you
Thank
have a.
you.
All right.
Thank you.
Okay, so for hypoparathyroidism, the only function of the parathyroid glands are to increase calcium levels. It does so by releasing the parathyroid hormone, and therefore it will cause the bone resorption. So the parathyroid hormone will get calcium from the bone and put it in the bloodstream for use in the body. So that is its only job. So there are therefore only two possible problems here in hypoparathyroidism, because you have a decreased production of the parathyroid hormone. So therefore it would also mean that you have hypocalcemia, and then vice versa in hyperparathyroidism you have an a decrease in the release of parathyroid hormone. So therefore you will have hyper what did I just say? Okay, anyway, hypoparathyroidism will have hypocalcemia. Hyperparathyroidism will have hypercalcemia. So this should be really fast because that's our only problem. So therefore, we only have two things to recognize, meaning what are the signs and symptoms of hypocalcemia, what are the signs and symptoms of hypercalcemia. And in fact, when we get to and of course the interventions will be, one will be for hypo, we will give the patient supplemental calcium plus vitamin D. Uh, and then for hyperparathyroidism, we will of course give drugs to decrease calcium levels. And as far as surgery goes, it'll be exactly the same as what we did for pre and post-op care for thyroidectomy. All right, so let's begin with hypoparathyroidism. So how does this occur? How does one get it? Thank you for reading, Miss Davian. How do you get hypoparathyroidism?
Let's see.
Okay, so
Uh,
start here.
uh, okay. Idiopathic, unknown etiology, acquired or reversible. Okay. The most common cause of acquired hypoparathyroidism is secondary to removal of the parathyroid glands during the total thyroidectomy or bilateral resection for cancer of the neck, the head and neck.
What about
Hypo Okay, yeah. Reversible hypoparathyroidism may develop secondary to iodine therapy for hyperthyroidism with metastasis of malignant tumors. Autoimmune disease is suspected in patients with spontaneous presentation of hypoparathyroidism with no identifiable cause.
all right? So this could be a select all out apply question. Which of the following are known causes of hypoparathyroidism? Select all that apply. All right, so this is where how those affect the parathyroid glands. So therefore, if it's primary, meaning the problem is with the the parathyroid gland itself, it's hypoactive due to the causes mentioned in the previous paragraph. So the body is unable to increase calcium levels. So it cannot get it from the bones, and it cannot also command the kidneys to reabsorb calcium. So as a result, the patient has low calcium levels. So what will be the patient's manifestations be? So we looked at these under post-op care in thyroidectomy. So the symptom, of course, especially if we're talking about severe hypocalcemia, is tetany, and we have Chbostik sign and Trousseau sign, along with the tingling sensations around the mouth or in the hands or feet, and then you have your muscle cramps and spasms. Please read this safety alert. This was also mentioned in thyroidectomy. You already know about the tracheostomy, right? Okay. So these
Yes.
are your labs. So I'll put your, just like in exam one. So you'll have new lab results here. Let me just explain the difference between total calcium and ionized calcium. These are different. The calcium is referring to the total body calcium, meaning these are the calcium found both in your bloodstream and also in your bones. Okay, this is the calcium level that they're talking about here. The ionized calcium is also called the free calcium. This is the calcium that's ionized. You know, when we write Ca++, so this is the free calcium that goes in and out of the cell, in the cardiac cells, in the skeletal muscle cells. So this is the free calcium that can go in and out. Calcium here doesn't have to be even a calcium as a electrolyte. This can be calcium that is already a compound, meaning this calcium is also, it can be calcium chloride or in whatever form the calcium is. Is that clear? So they're not the same. Okay, so when we say total calcium, that's total, this is the value, and ionized calcium has a different range. So again, this ionized calcium is the calcium that is freely entering and leaving the cell. Other numbers you should memorize, actually it'll be all of these, because magnesium and phosphorus also affects calcium level, because we have something called hypomagnesemia will also cause hypocalcemia. However, phosphorus is always opposite. So if you look at the pattern here under the third column under significance, so look at calcium and free calcium. They're both decreased in hypoparathyroidism. So is magnesium. So you can say, therefore, calcium and magnesium always go in the same direction. However, phosphorus is always opposite. So that's why you have here in hypoparathyroidism, you have low magnesium, but then you have high phosphorus. And then vice versa in hyper. Phosphorus is low, it'll be high in hyperparathyroidism. You follow that so far?
Yes.
Okay. So that's Chavostics. This is Trousseau. It's gone now. Of course, the diagnosis is based on the lab. So the doctor orders lab results, and then he'll interpret based on the numbers. Treatment. So you have low in calcium. So the treatment here is pretty simple. We will give you calcium. So we will replace your calcium. It can be given in severe cases when your calcium levels are 5 or 4, for instance, then the replacement will be intravenous. Otherwise, the patient will just be given PO supplements daily for life. However, it's important to note that calcium should never be given alone. It should be given with vitamin D, which is not a worry because most of our supplements anyway, when you take them, when you buy some over the counter, the calcium always has vitamin D in it, right? In fact, our milk, for instance, when you buy a gallon of milk, they always have vitamin D in it because it really doesn't make sense if you only have calcium but don't have vitamin D, because this one is essential for absorption of calcium. And these are your nursing assessments. So this is a summary of all your possible signs and symptoms. You can skip the ECG changes because we haven't done dysrhythmias yet. So we'll come back and test that later when we do module 8. And these are your interventions here. One thing to note is, let me go back to calcium supplementation, because the dosing here can be up to 2 grams of calcium. But the important thing to note is the safe dose should only be 500 milligrams at a time. Meaning if the patient is given 2 grams per day, how many doses will that be? Hello?
Can you repeat that? You said 2 grams per day, and the
Yeah,
dose is
the
800
doctor
milligrams.
may right. So the doctor may order anywhere between 1.5 to 2 grams of calcium per day. However, the safe dose should only be 500 milligrams each time because the kidneys can only handle that much. Because otherwise, if you give too much, whatever you give will be excreted by the kidneys because that's way too much calcium at one time. So how many doses will you give if the order is 2 grams per day?
If it's 500
milligrams?
milligrams, dose is 4.
Uh-huh. 100
Take
milligrams.
4.
All right, very good.
We did
4
4
doses.
doses.
Right, so it should be, so you have your morning or breakfast, lunch, dinner, and then one at bedtime. All right, so it should be separate doses. So here is your interventions and then teaching. I have a question on foods, on the diet. Thank you for reading this, Miss Sheila, about the diet.
Eat foods high in calcium but low in phosphorus. Foods high in calcium assist in raising serum calcium levels. Foods high in phosphorus are to be avoided because phosphorus can bind with calcium in the serum, further decreasing calcium levels.
Okay, so here's box 43-1. This is listing your foods. 43.1, foods used in the treatment of hypoparathyroidism. This one is on next page 909. All right, so I'll use these foods right here for the test. Fair enough?
Yes.
All right. Any question? That's it for hypoparathyroidism. It's really simple. Now let's go to hyperparathyroidism. What are the causes? This time is Lou. What are the causes of hyperparathyroidism? How do you get it?
Mute. Okay. Am I mute?
We can hear you.
Okay. Parathyroidinoma will be 85% of the case of primary hyperparathyroidism, and then another 15% will be secondary disease associated with hyperplasia of the hyperthyroid glands, and then also in patients with chronic renal failure or chronic malabsorption of calcium.
All right, very good. So we have primary, of course, this will be a usually a tumor in the parathyroid gland. That's primary, and then the secondaries usually are from kidney disease or some bowel disease. Let's say you have Crohn's disease. That's usually the problem. Or if you have, let's say, short bowel syndrome or any other stomach or intestinal condition, right? Anything chronic that affects your ability to absorb nutrients. So most likely, if you have a malabsorption problem, will hyperparathyroidism be your only problem?
No.
No, you probably have anemia or any other nutritional condition, correct?
Yeah.
Okay, so this one, therefore, if you have secondary hyperparathyroidism and it's caused by a malabsorption problem, this will only be one of your problems. You'll have multiple. All right, so this is the opposite of hypo. So in hypo, you didn't have enough parathyroid hormone. This one, you have too much. So now you have increased resorption of the bone. So now it will lead to bone demineralization. It will weaken because it will be constantly broken down for calcium. That's where the high calcium in your blood is coming from. It's coming from your bone. So let's go to manifestations. This will be the opposite now. So if you had muscle twitching, muscle spasms in hypocalcemia, what do you have in hypercalcemia? So your GI symptoms will be polyuria, anorexia, constipation, and you also have increase in gastrin secretion, leading to possible peptic ulcer disease. So knowing these without even looking at the interventions, what do you think will be your interventions for this patient?
Intake and outtake.
All right, I know.
Increase food, increase protein, no, calcium, constipation.
Increase hydration and fiber.
Very good. So hydration will be one of the interventions. What else? How do you get rid of the calcium? You have so much calcium here in your blood.
Diuretic.
All right, so diuretics and hydration will be given. What about, because we don't want to get rid of all the calcium though, because remember, where is this calcium coming from?
But Professor, would they give a diuretic if they got polyuria?
Actually, the purpose here is the diuretic and the hydration, which is a lot of fluids, work together. So how it works is you give lots of fluid, PO or IV first, especially if the serum calcium levels are so high, like 15 or higher. So that's severe hypercalcemia already. The patient may go into cardiac arrest, or other cardiac dysrhythmias may develop from the severe hypercalcemia. So giving the fluid will dilute the blood, causing immediate um, correction of the calcium levels. However, that will only be temporary. So you're only diluting the blood, but not really getting rid of the calcium. So when you give the IV fluids, NPO fluids plus the diuretic, not only will you have dilution, you will also have excretion.
Okay.
Does that make sense? Yeah, but the fastest intervention, of course, is the fluids first. Plus, you don't really want to dehydrate the patient either. So we can't use diuretics alone. So they kind of go hand in hand. So you give a lot of fluids to dilute it. And then when you give the diuretic, which will now eliminate the calcium, you will also at the same time prevent dehydration. Make sense?
Yeah.
All right. So what do we do now about this high acid now? We have to do something about that too.
Acids.
All right. So we can get
Inhibitors.
very good. So PPIs or H2 receptor blockers will be good. We really don't recommend antacids, especially calcium-based antacids here, because our calcium is already high. Plus, antacids will only be temporary. So the more efficient treatment would be, like you said, the PPI or the H2 receptor blockers. The other symptoms are weakness, fatigue, and bone pain. Because again, the hypercalcemia here came from the bone. So our diagnostic test, the same as what we did for hypoparathyroidism. So we draw blood and then look at the results. Treatment now, we started with fluid intake, like you guys said. You guys recommended this along with the diuretics. So here's the thiazide diuretics. No, not thiazide. We're supposed to give loop here, loop diuretics. So thiazide diuretics, why is it contraindicated, Miss Vivian? Probably muted. Miss Decker.
Sorry, I was plugging my Mac in.
All
What did
right.
you say?
Why can't we use thiazide diuretics? Can you read that highlighted statement, please?
Because they increase the reabsorption of calcium in the kidney.
All right. So we can use loop, but not thiazide diuretics. And here's a summary of your signs and symptoms. So in relation here, even though it's not listed in your textbook explicitly, but you know that there is bone demineralization, right? So therefore, what will be one of your interventions here for safety?
For fall,
Okay,
because of osteoporosis.
right. What about your activity? Because the patient has muscle weakness and atrophy. Will you put them on bed rest?
Yes, because they can fall.
Not really.
I mean, bed rest could further cause atrophy, but if you don't put them on bed rest, they risk balling and fracturing their bone and stuff.
So what do we do then?
Just limit their activity.
Yeah, limit the activity. Probably like, assist them while they walk in, little exercise probably every now and then, but don't keep them on
Okay, so what
strict
did you
bed rest.
let's let's be straight here. So what did you learn in fundamentals when patients have bone demineralization? What do we do? Do we encourage or do we limit activity?
Limit.
Limit.
No, we have to encourage
Don't we
activity
encourage
so the
encourage
bones
activity.
can.
them?
Yeah.
Oh yeah. We encourage it because when they don't, they
Okay.
start losing bone.
We
All right.
encourage activity so this way the muscle grows stronger around the bone.
All right, very good. So on top of your other interventions here, the hydration, we cannot have bed rest here because the patient already has bone demineralization. Therefore, if there's no stress on the bone, it will not regain strength, right? It will continue to be resorbed. So therefore, along with your therapy, so we have drugs, which we will do next. We also have activity. Okay, so especially exercise. That way, we prevent all these other problems. Because remember, here we have renal stones also forming. So if you're in bed all the times, and then that will precipitate the formation of the stones. All right, in severe hypercalcemia, of course, we put the patient now on cardiac monitoring. Um, here's the fluid and then the diuretics. Okay, so this one together, fluids and hydration and diuretic therapy. Phosphates, because this is the opposite, so you give phosphate so that will lower calcium level. This is your safety. So if patients have really, I mean, if the weakness is really severe, then of course we can't force them to get out of bed. But when we're moving them, it should be with safety. Use lift sheets because they are prone to trauma. And for renal stones, then you strain urine. Make sure we monitor for those formations or whether or not they passed it. And teaching. So calcium's already low, we give them a low calcium diet. Then because of the constipation, so you have your fluids again and fiber on the diet. And that's it. Any questions on hyperparathyroidism? So to summarize, hypoparathyroidism, you have hypocalcemia. Hyperparathyroidism, you have hypercalcemia. Questions will be on risk factors for both, diagnostic results, and of course signs and symptoms, and more importantly, what are our interventions for each. Questions? All right, let's take a break. Come back at 10:30.
Professor, you wanted to talk to the four of us like now, or you wanted to wait till after